Hi, my name is Amir Minerbi. I'm a family physician and a resident at the Rambam Pain Institute. And we're going to be talking in this talk about the pathophysiology of myofascial pain. Now, in previous talks, we saw that myofascial pain is characterized by several points. First, the first and most important thing maybe is pain. Pain can be either localized in the involved muscle, and it can also be referred to distal areas. The second thing is that the involved muscles show a reduced range of motion, and they're also weaker than normal muscles. And on palpation, when you palpate the muscles, they feel stiff and they are tender to the touch. Now, when we talk about the pathophysiology of myofascial pain, there are three main points that I want to make. First is a very old, by now, hypothesis that's called the energy crisis hypothesis that was postulated by Janet Ravel. The second one will be muscle tone regulation, or rather dysregulation of muscle tone. And the third point will be the neuroplastic changes that we see, especially in chronic myofascial pain. Now, let's begin with the energy crisis hypothesis. The energy crisis hypothesis, to understand it, maybe we should start by reminding ourselves of normal muscle physiology. So, normal skeletal muscles are composed of fibers, and these fibers are innervated by axons coming from the spinal cord. In order for a muscle to contract, what we need is an action potential coming from the motor neurons in the anterior horn of the spinal cord. This action potential then reaches the synapse, which is called the neuromuscular junction, which is basically a large synapse that releases acetylcholine to the synaptic cleft. And this acetylcholine is then absorbed or attached to receptors on the muscle itself. This causes the release of calcium ions to the cytoplasm of the muscle, which causes actin and myosin, the contractile proteins, to get into action and to cause the muscle to contract. This entire process takes up very little energy. What does take energy is the relaxation of the muscle, which requires the removal of acetylcholine from the neuromuscular junction, the removal of cytoplasmic calcium into the intracellular stores of calcium, and the disengagement of the motor proteins. And this does require energy that in the muscle, in the cell, is paid for in the currency of ATP. We've also heard in previous talks about the trigger points. The trigger points are maybe one of the hallmarks of myofascial pain. And when we look into these trigger points, we usually find them within taut bands. These taut bands are muscle fibers which are constantly contracted for some reason. When we look further into the trigger points, we see that they have measurable characteristics. They are different than the surrounding normal muscle tissue. They are different morphologically, they are different electrophysiologically, and they are different biochemically. Morphologically, we can now use advanced imaging techniques in order to see under the ultrasound the trigger points, which appear as hyperechoic foci within the muscle. And it's interesting to note that when we treat the muscle, these hyperechoic foci disappear. So we think that these are actually trigger points. And histologically, what we see there is a disarray of the muscle fibers, which are basically messy muscle fibers. Electrophysiologically, trigger points show spontaneous firing and early fatigability of these involved muscles. And what's maybe the most interesting characteristic is the biochemical characteristics. This is based on a work done by Shah and colleagues. And what they did was they used microdialysis, which is a very fine needle put into the milieu of trigger points. And they were able to analyze the surrounding of this trigger point, which shows basically a hypoxic surrounding, poor in ATP and acidic, and rich in calcium ions and in acetylcholine. So maybe now we can try to arrange things in a clear model, something like that, an initial insult to the muscle that causes it to contract for prolonged periods of time. It can be acute or chronic, but what it causes is a contraction that becomes anaerobic contraction. This causes the levels of oxygen to drop, which causes two processes. The first is the depletion of ATP in the muscle, because oxygen is needed for ATP to be produced. And the lack of ATP causes an increase in calcium and acetylcholine. We saw before that ATP is needed for the removal of calcium and acetylcholine. The accumulation of these substances causes contraction of the muscle. The muscle is unable to relax, and the muscle is remain contracted. This is perhaps the reason why we find taut bands within the muscle. The other process that hypoxic environment causes is acidity. The transfer to anaerobic metabolism causes the pH to drop, which in turn causes the release of several analgesic substances such as substance P, calcitonin gene-related protein, and bradykinin, which are all able to directly cause pain and also indirectly cause pain by promoting inflammation. Pain, we know, leads to contraction. Even if we are unaware of it, pain leads to muscle contraction. And this contraction further causes vascular compromise, which further depletes oxygen supply to the muscle. And this, in short, if you want, is a vicious cycle that is based upon contraction and pain, pain leading to contraction, and contraction leading to pain. So this, in short, is the energy crisis hypothesis. Now let's look a little bit into muscle tone regulation, or muscle tone dysregulation, if you want. Normal joints have flexor and extensor muscles. And these muscles, the relative contraction of the flexor and of the extensor, determine the position of the joint in space. The tone of each muscle, both of the flexors and of the extensors, is maintained by the spinal cord. And this regulation of the tone of the muscle in the spinal cord is based on input coming, on proprioceptive input coming from the muscles, from the tendons, from the joint, from the skin, from the fascia, from all of the somatic tissues that surround the muscle. But not only locally. The muscle tone is also regulated by higher levels, like hypothermia when we are cold or when we are in emotional stress. This may increase the muscle tone. And on the other hand, when we are sleeping or when we are using relaxation techniques, this can lower our muscle tone. And this is what is happening physiologically. This is the normal way these things happen. But the interesting thing is that in myofascial pain syndrome, muscle tone seems to be dysregulated, which leads to shortened and over-contracted muscles. And different treatment approaches, manual treatment approaches, such as dry needling or IMS, intramuscular stimulation, as well as other treatment modalities, seem to alter the afferent input from the muscle to the spinal cord, and That way, they cause a relaxation of the muscle. It's also interesting to know that conditions that we know lead to increased muscle tone also are predisposing factors for myofascial pain. And these conditions, among others, we have muscle loading, if we are carrying a heavy load for a long period of time, exposure to cold, psychosocial stress, hyperlaxity of ligaments, and muscle weakness. All of these cause increased muscle tone and eventually may lead to the development of myofascial pain. So we may now expand our understanding of the energy crisis model a little further. We can introduce weakness, muscle weakness, to this model. This weakness causes the muscle to over-contract in order to develop the same amount of force. The muscle has to work harder and it contracts harder. This causes pain, as we saw before in the energy crisis theory. Pain may lead to avoidance because patients who are in pain may avoid activity which increases pain, and avoidance over time will aggravate weakness. So this vicious cycle is a little bit more elaborate than the previous one. The other point is neuroplastic changes. Neuroplastic changes are something that we see especially in chronic myofascial pain. Now, all of us probably have experienced myofascial pain during our lives. Those of us who haven't probably will. So we think there's some kind of a primary insult causing acute myofascial pain, but the thing is that most patients will recover pretty quickly from acute myofascial pain, and only a small part of the patients will develop chronic myofascial pain. And when we talk about chronic myofascial pain, we should understand that it's a very different entity than acute myofascial pain, not just because it's longer in duration, but also because it's different in the neurobiology of the phenomenon. When we look at patients with chronic myofascial pain, what we find is that there are neuroplastic changes at multiple levels of the neural networks, of the neural system. First of all, in the peripheral nervous system, there are alterations both in the neuromuscular junction, in the synapses in the posterior horn of the spinal cord, and in interneurons within the spinal cords. But it's not just in the peripheral nervous system, it's also in the central nervous system. Recent works done have shown that there is an atrophy of gray matter in different areas of the brain that are responsible for pain modulation, for pain assessment, and even for negative affect. And the last thing, very interestingly, we see that many times there are also changes in the autonomic nervous system, which cause different signs that we can see on physical examination of the skin. So why would some patients develop chronic myofascial pain while most patients don't? We think that it has to do with something that we call perpetuating factors. These perpetuating factors are factors that predict who may develop chronic pain while others will not. And we divide them into three categories. The first category, maybe the most common one, is mechanical perpetuating factors. We'll go into more detail of these factors when we talk about, in our last talk, about building a comprehensive treatment plan. So the mechanical factors are the first group of perpetuating factors, the second one being psychosocial factors, and the last one being metabolic factors. How do they contribute to this vicious cycle that we saw before? Well, mechanical factors may, like, say, ergonomic factors, sitting in front of a computer of which the screen is on the right side. So this may cause prolonged loading of the cervical muscles, which cause them to contract for prolonged periods of time. Other mechanical factors, say like in spinal surgery that causes fusion of several lumbar vertebra, may cause weakness by causing atrophy of the paraspinal muscles. Psychosocial perpetuating factors may cause avoidance because most patients, or many patients, when they are in pain, try to avoid aggravating the pain, so they avoid several activities that may aggravate pain, like physical activity, like work, like social activity in severe cases. And this avoidance is aggravated by several psychosocial states like depression, anxiety, and litigation. But not only that, psychosocial states may also aggravate pain, because we know that people who are depressed or who are anxious have lower pain thresholds, so they sense pain in a stronger way than healthy people do. And last are the metabolic factors, which we don't really know how they contribute to the perpetuating of the vicious cycle, but we do know that there are some clinical correlations or statistics that show that they probably do. One last point before we conclude is the question of referred pain. How come pain arising from muscles can radiate to distal or to distant locations? We know it happens. We know, for instance, in this drawing, we see the pain referral pattern of the longus colli muscle. It's a deep cervical muscle that is, when it's involved in myofascial pain, is not only painful locally, but also radiates pain to the ear, to the eye, and even to the contralateral neck. And this referral pattern is not, does not comply with any dermatome that we know. So how does this happen? We think that this can be explained by convergence of afferent fibers, nociceptive afferent fibers, coming from the involved muscles, but also from other somatic organs, like the skin, like joints, like fascia, and other somatic structures. And this convergence causes retrograde activation of these uninvolved fibers. So let's say we have pain in our longus colli muscle, but this area of the spinal cord which gets the nociceptive axons coming from our longus colli also gets afferent fibers from our ear or from the contralateral side of our neck. This will cause a retrograde activation of these fibers, which will trick the brain into thinking that these areas are actually in pain when they are not really. So to conclude, we have seen that myofascial pain typically develops in overloaded or weak muscles. The trigger points, which are the hallmark of myofascial pain, are characterized by a milieu of hypoxic, poor in oxygen, and acidic. That perpetuating factors may lead to chronicity of acute myofascial pain, and that chronic myofascial pain is often linked to neuroplastic changes at multiple levels of the nervous system. So at this point, I want to thank you for listening, and goodbye.